Hello everyone, this is Sameh Sayfo, interventional cardiologist from Baylor Scott White, the Heart Hospital, Plano, coming from Dallas, Texas. Today we're going to be covering the Javelin technology. Last presentation we had, I promised that we're going to bring this technology to the audience. We're going to be part of the series of recording with Murmur MD, the peripheral channel. This is basically focused on the new technology, Javelin technology, the single emitter technology from Shockwave Medical in treating a patient with heavily calcified vessel. The three factors we mentioned on the slide, including advanced age, diabetes, and kidney disease, increase the complexity of patient with critical limb ischemia, because they increase the prevalence of calcification, the calcium also increase the chronic total occlusion percentage on those cases, and multi-level peripheral arterial disease. So what are the treatment options for uncrossable lesions? When we cross a lesion, the lesion with a wire, but we are not able to deliver a balloon or a next device, we have limited options. We have atherectomy, and when we say atherectomy, only maybe two types of atherectomy that we can deliver that do not require specialty wires. And not every hospital have those atherectomy available, like for example laser atherectomy. Smaller balloon may be an option. The disadvantage of a smaller balloon, that if you inflate the balloon there with heavy calcified vessel, you may end up causing dissection. The balloon may rupture. Microcatheter can be useful, may or may not cross, and if you cross, you can switch to a different wire and perform some kind of atherectomy to help cross this lesion with the balloon next. Javelin is an option we're going to discuss today in more detail, and of course retrograde access with the pedal access sometimes be very useful. Covering therapy for calcification, we presented this last talk, but I think it's very, very important slide to present, and you've seen this slide presented in many conferences before. When we talk about atherectomy, you're talking about directional atherectomy, which basically HOC1 has excellent result with mild to moderate calcified lesion. It has a risk of disembolization. We recommend embolic protecting device in most of the cases, and sometimes it's very difficult to do so when you're doing below the knee vessels. Diamondback with CSI, it's a great device. The only issue with it requires its own wire, which in some cases we cannot cross with a microcatheter to switch to that wire. It'd be challenging, but it's a really good device as well. Laser atherectomy, both excimer laser and Arion laser works great for calcification, mild to moderate calcification and instant restenosis. Rotational atherectomy, including Roto, Jetstream, Phoenix, or Rotarex, also an option for some of those cases. Some of them require their own wire that you have to use it, and the others may not be available in your institution. Just another summary about the atherectomy devices between advantages and disadvantages. If we talk about a rotational atherectomy, it's very effective in calcified lesion, very fast, but that device does not moderate the depth of the atherectomy. It's really shallow. In directional atherectomy, it's great, but we talked about it. Disembolization is there's a high rate of disembolization in directional atherectomy. There is definitely a vessel wall trauma if you become too aggressive. And of course, it's time consuming, requiring multiple passes that require to clean that device regularly. Orbital atherectomy is a good method. We mentioned the limitation, cannot do it in ISR, and we cannot do it without having its specialty wire, which is the Viper wire. Laser, including excimer laser or ISR or Arion laser, some believe that they're not as effective for severe calcification, even though there's data for severe calcification with a micro CT, but it's not available in every hospital. What are the atherectomy downside? Dissembolization, dissection, steep learning curve, and possible perforation, and of course, availability and cost. Just an example of paper discussing, atherectomy possible complication, comparing POBA to atherectomy. And you can see a significant difference between the two. Let's talk about Javelin. Why do we care about this new technology? The IVL technology was a game changer when it was presented early on. And we learned that it's not only effective, but it's really easy to use. And maybe that's one of the two out of three reasons why it became very popular. The third reason is the safety margin. With all the data, PAD 3 trial, both the observational study and the randomized study showing a very low rate of complication. One of the concern operator had early on that in a case like the case on the left side, where the balloon can get to the calcified lesion, but the emitter is further out from the tip, so that energy is really not being delivered to the calcium to break that calcium. And because all this feedback the physician has provided the company over the years, the engineers were listening, and they came up with a device called Javelin, which is a single emitter, non-balloon based lithotripsy. If you notice, comparing the left video to the right video, is the emitter is significantly further to the tip of the catheter in the Javelin device, which allow us to break that calcium and create that channel more effectively. Let's talk about the specifics of the catheter. It's not available in every hospital. It's becoming more and more popular and more available. It was a limited release, but now it's commercially available. It required the same console that we use for all the IVL balloon with shockwave. So if you have that console in your hospital, you'll be able to utilize this device. It is a crossing profile of a 1.5 millimeter. It's an 014 guide wire system. It's compatible with a 5 French sheath. The catheter length is 150 centimeter, and that was intentional because the idea is that we're going to use this more in below the knee vessel, but we still use it in probably an SFA in certain cases. Pulses are 10 pulses per cycle. You have 12 cycles with a total pulse of 120. We will discuss that distal end and the proximal end of that device in the next slide. At the distal end here, you have the energy deliverability of the emitter. Not only it doesn't come forward, it comes as a sphere, so it affects the side and further forward, and that's what we call the forward study, the forward energy. But it's not just a forward directed energy. You have a catheter connector, is very similar to the other IVL balloons. The emitter and the emitter is slightly behind the tip. There is a window there, and it's important to talk about this. We said it's not a balloon-based IVL, but there is still a micro channel that goes from the inlet port to the tip through that window back to the outlet port. And the reason we have that is because when you get that energy, you create this micro bubble, and we need to flush it out to continue to deliver the energy in a more effective way. We'll go on a video next to discuss how you prep the device and how to utilize it. Also want to emphasize the importance at the 150 centimeter catheter, shaft catheter. The first 25 centimeter is the flexible catheter, and the remaining is a little bit more rigid. It is hydrophilic coated at the distal 50 centimeter. The guide wire port is very similar to over the wire device. It's not a rapid exchange. Here to look at a comparison between the balloon-based shockwave IVL, not specifying which one, just talking in general, versus the non-balloon based shockwave IVL, which is the Javelin technology. If you look at the balloon based, you look at it delivering the catheter into the lesion, and then you inflate the balloon at a low pressure up to 4 atmosphere. You deliver the energy, and the emitter will create this sonic pressure wave, creating this energy that penetrates through the media and intima and break that calcium. And that's how the device become effective, creating more compliance and expansion of the vessel. And the vessel expands safely with a low risk of disembolization or perforation. Where in the Javelin technology, which is the non-balloon based technology, you deliver the catheter as deep of the lesion as you can deliver it till it stops. You start delivering the energy, which generates sonic pressure wave that comes as a sphere, not only forward but also sideways, and delivering this energy through the calcified plaque and modifying the calcium, allowing the catheter to advance further deep, and you continue to deliver the energy as you push it forward. That allows you to create not only a channel, but sometimes can effectively treat this calcified lesion. One of the issues and concern that many physicians had is that if you look at the available femoral popliteal balloon-based IVL, they are 60 and 80 millimeter in length, and there's 40 millimeter in length. But we have cases where you have a rock of a calcium, but it's very short, and you want to deliver that energy right at that spot without having to inflate the balloon in a 60 millimeter or 80 millimeter anatomical area. And I think that's where Javelin can be useful as well. As we mentioned before, you don't have to have a new connector or cable. It's the same connector as we have, and the same as the generator. So use the one you have in the hospital, and you only need is the Javelin device. Do we have any data to support the utilization of this device? The answer is yes. There was a study that finished last year and was published at Viva of 2024. It's called the Ford PAD IDE trial. We're lucky at Baylor's County-wide, the Heart Hospital planned to be part of this study, and we're the second enrolled in this study. So we got some experience there, in addition to a lot of other very talented operators who helped enrolling a lot of patients there and got a lot of experience. We learned from each other. It's going to be very similar slides that you guys have seen comparing to the other studies like PAD-3 trials and other trials that Shockwave has shown. It's a safety and efficacy study, modifying calcium across severely narrowed above the knee and below the knee lesion. This data is presenting in 90 patients over 19 sites, 103 lesions, and we're looking at a 30 days follow-up. We'll have a 1-year follow-up hopefully soon, and we'll have the full study, which is more than 100 patients. If you look, all of the lesions were core lab educated. We looked at the pre-procedures. The average stenosis was 83%. Post-Javelin was down to 59%. Remember, this is a device to crack the calcium to be able to deliver future other therapy to it, or final therapy to it. Post-dilatation, we were down to 31%, and final result at 23% residual stenosis. The study said it's successful if you have more primary effectiveness endpoint achieved when residual stenosis less than 50% without flow limiting dissection, and that was achieved in 99% of the cases. What about safety? And I think that's extremely important. The major adverse event at 30 days was 1.1%. One patient of the 90 patients had a death that was not related to the treated limb and not related to the procedure or the device, but nonetheless was within 30 days, and that was calculated here. What about other metrics of the study? We looked at the procedure length was around 100 minutes or so. Only 3% of the patients, or 3 patients, or 3 lesions basically, required a pre-dilatation to be able to deliver the javelin. Number of javelin used, most of the time only one javelin catheter used. Around 8 to 10% of the patient required 2 devices or more than 2 devices to be used. 93% had a device success to be able to reach the lesion that need to be practiced. It's a little bit deceiving to say maximum pressure used in Javelin because we said it's not a balloon based, but if you be patient with me for the next couple of slides, I will explain what that means. Even though we do not have a balloon, but we still generate a pressure through that microchannel that has saline in it. Mean pulses delivered is 89 pulses out of 120. Post-dilatation performed on almost all the cases. And what about what's the percentage of cases where we delivered a balloon-based IVL? 1 or 2 were delivered in a quarter of the patients. Embolic protection device were used in 7 cases out of 105, so 6% or so. All of those 7 cases had no debris found in the distal embolic protection device. And those cases are the cases where a physician thought if this patient has single vessel runoff and want to make sure that definitely there's no disembolization. And in those cases, we found no debris in the filter. Drug-coating balloon was used only in 40% of the cases. Again, remember this above the knee and below the knee. So the below the knee, as there's no data in the United States for below the knee DCB, that was not used there. The good thing is that we wanted to make sure that this is not an operator guided operator reported complication. We wanted to look at the core lab and make sure that that is accurate. So if you look at the core lab, post-Javelin, there was 1.2% serious complication, including dissection, but there was no perforation, distal embolization, or prop vessel. When we looked at post-dilatation, that went up to 4.1%, just aggressive post-dilatation, and at the final, with the final therapy, there was 1%. 1 out of 98 patients had a dissection that is type D or F to F, but no perforation or disembolization or no reflow or thrombus. So what this study has shown or summarized, the Javelin through the modification of calcium is safe and effective device to cross a heavy calcified and severely stenotic lesion. It's also shown, like similar to the previous balloon-based IVL, that it is a safe option and consistent and can be available as a combination therapy or a sole therapy to modify calcium. I don't want to dwell on the same data, but has shown that majority of the cases that a Javelin and a PTA balloon alone was effective to achieve the result that we wanted to achieve in this patient, especially for below the knee disease. I promised to discuss a pre-procedure device prep because it's a little bit different than how we prep a balloon-based IVL. And we're going to go over it. You're going to see a video here and do step by step, then we're going to go through it. You prep it in the same way you prep anything else, in a sterile fashion. You achieve the act. You deliver your wire. Make sure that the package is not damaged and there's no baggage compromise there. And you put it on a sterile field. What I would recommend is you bring a new deflator, and you put only saline in it. No contrast in that deflator is required. Would not use the same deflator we have that we use contrast in. And we have a stopcock on the out port, or the outlet port that we have, and the deflator on the in port or in outlet. And what we do is we start pushing the deflator up to generate around 6 mmHg, and then we close the stopcock, and you notice that the pressure will slowly settle down to around 4. At 4, you start delivering energy and slowly pushing forward while you're holding the guide wire. And let's just show you an example. We start with filling an inflator with the syringe. This is the outlet where you put a stopcock there. You open it up. Saline filled inflator which is going to show it there. While the stopcock is open, you start inflating till get around 6 here, and whenever you get 6, you will see a drop of saline coming out. That will confirm that there are no bubbles that present in the microchannel. When you close it, you will notice that the pressure is around 4. Now you deliver it over an 014 wire, hook it up, turn it on, very similar to what we had in all the IVL, balloon-based IVL. Of course, that will be sterile. You will get a sterile plastic bag that will be in a package as well. And you connect it, and that will tell you that you have 120 pulses, and will recognize right away that this is a Javelin device. You deliver the 10 pulses in the cycle, then it will pause. It will give you a pause of 10 seconds. That's your time where you open the stopcock and you slowly go up on the inflator, again around 6. Around the 6 mark, you will notice a little bit of drip of the saline in the distal part of the stopcock. Then close the stopcock again and repeat. Very similar. You do it every single time the same way. It's very important that every time you get a 10 pulses per cycle, when you finish that cycle, you need to flush out that microchannel. Extremely, extremely important to have more effective Javelin. Video. So you go in, you deliver it to the calcification, you already flushed it, you're ready to deliver the energy, and now here you go, you inflate it to here, already here close the stopcock here. If you have it open, I recommend going to 6. You'll see it dripping, and then you close it, and it will go down to 4. You turn it on, it's recognizing at 120. You start delivering pulses, and you see it will crack that. You can stay where you are. The recommendation from the operator is try to continue having a slowly push forward while you're delivering the energy, so you can move forward closer to the calcification. That's what we talked about. Now you finish the cycle, you open the stopcock, you inflate up to 6, you see the dripping of the saline, and then you close it back. Make sure it's at 4 before you deliver the energy. Again, you get it all the way in, you deliver the energy, and you push forward. I would like to finish this talk with a few examples, and we will have a separate recording, me and Dr. Banyan, where we're going to discuss a few cases, few techniques, especially for below the knee, but I wanted to give you a combination of cases. Some of them were part of the trial, and some of them are cases that we did during the initial launch of the product. 65-year-old male with history of CKD diabetes came with worsening claudication. He failed medical therapy and walk and exercise. Ultrasound and CT showing occluded right SFA. So regular classification 3, failing medical therapy. This patient right away you can tell CKD and diabetes, they're going to have a lot of calcification. If you look at it, when we did the first angiogram, you can see a completely occluded. You can argue that what about doing fempop? This is not the point of this conversation. But in this situation, we were able to deliver the wire across through that occlusion, severely calcified osteal SFA. We delivered the Javelin. You can see post-Javelin now you have a channel. We delivered a post-dilatation balloon, a gentle inflation, and finally we delivered a short stent in the long DCB, and we did not have to deliver any stent in this situation. It's an area that you really want to avoid putting a stent there. If you see the bifurcation in the common femoral. So the javelin here not only helped creating a channel, but also it helped cracking that calcium that a DCB was delivered and the lesion was treated without any dissection. If I look at this case again and I want to do something different, what I would do different is in this case is after I deliver the javelin, I will deliver a modifying balloon, either an E8 as a shot as an IVL, or some specialty balloon like a serration balloon or a cutting balloon as a combination therapy. This one we did it specifically post Javelin, wanted to see how effective this device is, and it looks pretty good here. This is a patient, to show some pictures here. This is more of a below the knee, single vessel runoff, patient with a critical ischemia Rutherford 5. And you see this is just a single vessel that's dominant perineal here and severely calcified. You see a lesion at the distal pop and also at the TP trunk. And we're delivering Javelin for both of those lesions. And we're very, fond of delivering IVUS and utilizing IVUS. We don't have the IVUS picture here, but we definitely use IVUS in this case. And we delivered post-dilatation balloon, and this is the final result. Excellent result with no dissection, and we preserved the single vessel run-up in this case. What about more complex cases when it's not just one short segment? It's more of a sequential lesion in the same, but especially with the severe claudication Rutherford 3, failed medical therapy, see a diffuse SFA disease with this very tight SFA lesion. This maybe around 90% or so. If you look at segment here, this is one lesion there. There's a couple of lesions further up. There's another lesion here. You can argue if you're able to deliver an IVL or able to deliver a Viber wire, maybe you can do a CSI requiring a filter here, maybe. Or without a filter, hoping it doesn't have disembolization, or maybe E8 to deliver the energy. But I wonder, even with the E8 being very slick, balloon would be able to deliver through this tight lesion. In this case, what we did is we actually did Javelin. You look at post-Javelin, doesn't look super impressive here. So, you think, did this device kind of fail? But we did IVUS. Again, you see a lot of crack in that calcium, in that spot. Remember, this Javelin is not to give you the same result as an E8 with the 400 pulses. This is only 120, one emitter. It's more to create this channel. But the more and more we did, when we focus on the spot, which is very calcified, we actually have seen some of the cases where it deliver a very similar result as the balloon itself. Here, unfortunately, I don't have post-ballooning. I'm not sure how that happens, part of the study. And this is the final result. Maybe 20%, 30% residual, no dissection, good flow, no stent is needed. Let's go a little bit more complicated case. This is a case where we've done multiple therapies. This is case 4, 78-year-old male, history of hypertension, CKD, diabetes, and AAA post-EVAR. Coming to us with worsening right side claudication, Rutherford 3, ultrasound showed multi-level SFA stenosis, heavily calcified. I'm a big fan of radial access. This is something we can discuss on the different talks. Especially with EVAR patient, radial to peripheral has been an amazing technology. We still have some limitations, especially with the IVL. We actually attempted via radial access, but we could not cross the multi-loop iliac artery. So EVAR is there, but the external iliac is extremely tortuous. We could not cross there. We brought the patient back with the thought to go pedal access with the radial just for pictures. We accessed the anterior tibial axis, anterior tibial artery, and this is the picture. You see multiple calcified plaque in that SFA. Retrograde, and in the middle picture show you the Javelin catheter, and the tightest lesion was this distal SFA. There has some tortuosity to it. And we're able to deliver 120 pulses, maybe 60 of them or so, around that spot in the distal SFA, and the rest was in the more of the mid SFA. We took pictures, we liked it, but we thought maybe we needed to have a little bit more calcification management, and we followed the E8. If I believe it was a 6 by 80 E8 catheter. The final result was with DCB. Whenever I go pedal access, the first thing I do is actually get a pressure as my baseline pressure. That helps me decide when what I call this a successful procedure or not. This patient had a gradient of 80 millimeter of mercury. We did IVS post Javelin showing severe cracking. So this is pre-Javelin, severe calcification, more than 270 calcium, all this spot from 2 o'clock. The only thing that doesn't have calcium is 2 o'clock to around 6. Everything else is severely calcified with this shadow in there. And then this is after with Javelin, and you can see better flow there. Yes, still some calcium, but now really the calcium can kind of regrade it further back. We did a long DCB, and geographically may not look pretty, and people may want to do stenting in this situation. But what we're dependent on is that they're actually the gradient went down from 80 pre, taking that pressure from the pedal to less than 20. It's a successful procedure, not requiring a stand, and I don't have any dissection that I'm worried about. So that was the final outcome for this case. As the series grow, I want to promise with the next talk every single time. And our next talk actually will be discussing cases with Dr. Obanian about her expertise and her experience with Javelin and when to use it. The next one will be discussing the common femoral artery endovascular therapy option. This is a topic that's very exciting to many of us. Common femoral endarterectomy versus IVL versus atherectomy versus now stenting, which is common in Europe with some strong data. So look forward to meeting all of you in the next recording discussing common femoral artery endovascular therapy option. Thank you.